Welcome to the PT on Ice Daily Show brought to you by the Institute of Clinical Excellence. My name is Dr. Jeff Musgrave, Doctor of Physical Therapy, proudly serving in the older adult division. So today, our episode is going to be about mild cognitive impairment and falls, what you need to know. So ran across a really interesting study titled Perturbation-Based Dual-Task Assessment in older adults with mild cognitive impairment. So many of us know that with mild cognitive impairment, there is cognitive decline and dual tasking is affected to some degree. But to what degree and how that may impact balance performance, walking performance, there's still a lot we don't know. Oftentimes, I think we look at physical reserve and talk a lot about physical reserve, the difference between what the task is physically and how much extra you have. For example, if you have to pick up a 40-pound bag of dog food and you can only lift 42 pounds, you've got very little physical reserve to be able to complete that task. The reality is we have the same thing with the cognitive system. So in that same example, if you can only lift 42 pounds, the dog food is 40 pounds, very little reserve. For the cognitive task, it can be the same thing, where maybe we hit someone's max capacity by asking them to walk and have a conversation on the phone. Or maybe they're distracted by traffic walking through a busy parking lot of a grocery store, which could be a high-risk scenario where they may fall or they may not attend to traffic and could get injured. So that cognitive reserve can have real impact on the older adults that we treat. What this study was doing was trying to figure out where older adults' balance breaks down when they're doing dual motor and cognitive tasks while they were on a treadmill. So they had 15 older adults on without cognitive impairment and then 15 that had a cognitive impairment on board. They put them on a treadmill and they asked them to perform both dual motor and dual cognitive tasks while they were also experiencing perturbations. So very cool study, very complex intervention, which I can really appreciate. And when they looked through the results, they found that those with mild cognitive impairment had lower cognitive reserve. They had less ability to attend to the walking task, to recover from perturbations. They also found that they had more errors on their cognitive tasks. So they had many more replicated falls during perturbation-based training because their inability to do both motor, dual cognitive tasks while walking. So I think this brings up an important point that reserve is leading to real problems in our older adults that are of the same age. So the reality is this study, if you dig into it, it would be challenging to replicate 100%. For me to say you're going to see the exact same thing in your older adults, or that you need to use these type of interventions that used to see the difference in performance here, because they had a light board and different games, and we don't all have above treadmill harness systems that we can use to do perturbation, dual motor, dual cognitive task. However, we can walk people with a gait belt. We can put them in real life scenarios for walking, get them outside the clinic, get them on uneven surfaces, and then ask them to do dual motor tasking and to do dual cognitive tasking while we're performing gait training, while we're doing perturbation training. We can replicate the interventions that were used here. However, they didn't do this for a training effect as much as to see what the difference in performance is in these scenarios, but it does show a significant difference. So I think some things we really need to take away from this study is screening is vital. If we're not screening for cognitive status, we need to be doing that, or we need to refer to someone who will. But early intervention for mild cognitive impairment is going to be way more effective than waiting until an older adult has full-blown dementia, right? We know that interventions tend to be less effective in later stages. So for those that don't have mild cognitive impairment, building that reserve is key. Building cognitive reserve after we screen them, crucial. But also understanding once someone does have mild cognitive impairment, we don't shy away from those dual motor and dual cognitive interventions. We actually need to bring them more to the forefront. We need to incorporate them more into our sessions. So I think that's key, is the screening piece. So tools like the MoCA can be really beneficial, but you need to make sure that you are trained to do it, that you are confident in doing it. I don't recommend just Googling a form and making a diagnosis for someone, right? We need to really study how to execute these tests well so we can perform these assessments. Some of them require training. If you have an interest in it, by all means, add that skill to your toolbox so that you can effectively screen for cognitive impairment, so you can prioritize these interventions for your patients. But if you're not going to do that, find out who can in your area. Make it really easy when you run into these scenarios. Here's a doc whose office is good at screening it. Here's the occupational therapist who's really good at cognition that can help me screen this. Here's the speech therapist that I work with that I need to make a referral to, or outpatient speech, or some type of center on aging may also have professionals that can do that. So screening is crucial. I think that's the foremost takeaway first. The second piece is we need to build the cognitive reserve. Okay, we know it's on board. We know how much of an issue this is. Now we have to put it into practice. So we've got to design our interventions to have both dual motor and dual cognitive task. Those are completely different categories, and we need to treat them as such. So we've got to include them both when we do our dual tasking. And we want that to be in environments where their balance is breaking down, right? That's part of what this is showing us. The breakdown is happening when there's dual motor and dual cognitive task on board for all older adults, but even more if you have mild cognitive impairment. So this has to be part of our interventions. Just static, just dynamic balance, just our obstacle courses, it's not enough if we're not adding dual motor and dual cognitive tasks. And the more we can make this real life, the better. I did a carousel post earlier in the week through the ICE account, and Mike Studer, if you are familiar with him, a very prolific researcher in this area. If you've studied dual motor, dual cognitive task, and he commented on the post and just made some just great recommendations that if you're going to be adding this, and adding dual motor and dual cognitive task are new for you, to make them as real life as scenarios as possible. Ask them what their conversation topics are typically about, what their occupation was, or questions about it, or to name things from that. But to reduce the fear on some of like the math type interventions, which are effective, but someone who truly struggles with that or is fearful they're going to feel stupid or not going to perform well, they're not going to engage with you as much. And you can also ramp up the intensity really well by making it very specific to the person in front of you. So those are just some tips if adding dual motor, dual cognitive task are new to you. So that's number 2. And then the third piece is perturbation training is very beneficial, but it has to be in an appropriate intensity to be beneficial. So for perturbation-based training, you need someone to be eliciting a stepping strategy. You need to be pushing them to the point where they have to take a step. If we're just gently pushing into their body and they're not moving their center of mass outside their base of support, we're not really providing a perturbation. We're probably giving them a soft tissue mobilization. So just check in on your intensity. Also be mindful as you're increasing the intensity, you don't want to increase the speed too fast, because then you're just doing this ping pong effect and you're pushing them around. We need to give them time to respond. So those are the big takeaways here. We've got to be screening for mild cognitive impairment, because we need to know if it's on board so we know how much to prioritize that in our sessions. Number 2, we have got to build cognitive reserve through dual motor and dual cognitive training. And then the third piece, with everything. The dose makes the poison, right? We've got to hit an appropriate intensity with our perturbation training, with our cog and our motor tasks that we're adding. Team, I hope some of that was helpful for you. I hope that you are already adding these things into your clinical practice. If you're not and you need some help, we would love to help you. These are some topics that we cover very well in our curriculum. We just started, if you're looking to join us for a course, we just started level 1 and level 2 for this cohort. Next cohorts will be for level 1 will be March 17th. Level 2 will be May 13th. As well, we'll have a cohort of level 1 at the same time as that May date. And then our live courses are kicking off. We're starting strong in Tennessee. That might already be full. There might be a seat or two there, and there might be a seat or two in Idaho on the 25th. So 18th, 25th of January, Nevada will be there in February. We've got lots of great bookings across the country this entire year for MMOA Live. So if you've not seen us live, it's a great time. We really dive into motor dual cognitive, dual motor tasking, perturbation training. So if that's new, we'd love the opportunity to help you. If you have any thoughts, questions, things that you like to use for motor dual tasking, cognitive tasking, feel free to leave a comment. Other than that, team, have a wonderful Wednesday, and we will catch you next time.